Hi there, everyone, and a warm welcome to this eMHIC webinar. My name is Maureen Abbott from the Mental Health Commission of Canada, and it's my pleasure to be your host for today's webinar, where we will reflect on the powerful insights from eMHIC 2024 Congress. And today we'll explore the enduring challenge of clinician engagement in digital mental health and ask whether it's time to rethink our approach. And today we're lucky to be joined by field experts who all bring distinct perspectives on the path forward. Together, we will explore clinician and patient motivations, practical barriers, and potential breakthroughs that could transform digital mental health care. We'll look closely at innovative strategies from public health initiatives and co-creation to policy changes and evidence-based design to address the critical question, how can we empower clinicians to drive real impact in digital mental health? You'll hear from our speakers soon, but first I have a few quick points to mention. Feel free to share your current location or area of interest. And to do so, you can click on the three dots next to your name tag, choose edit, and then add your country or your area. And this allows you to connect with others who share similar interests. And if you have any questions for the panelists during the webinar, please feel free to post them in the chat box. And during the Q&A session, I will do my best to include as many of them as possible in our discussion. And even during the back and forth discussion today, we will still try to incorporate questions. And lastly, today's webinar is being recorded, and the eMHIC team will soon share the recording in the Knowledge Bank. And now it gives me great pleasure to briefly introduce our esteemed panelists, Tom Mickelwright, Sue Baker, and Professor Nick Titov. Hi, everyone. Nick, could we start with you for the introduction, please?
Hi, Maureen. Thank you very much. Hi, everybody. My name is Nick Titov. I'm a professor of clinical psychology at Macquarie University in Sydney, Australia. I've been involved in research and teaching and practice in digital mental health care for quite a number of years, but my main role is serving as the executive director of the Australian MindSpot Clinic. Now, very briefly, MindSpot is an Australian national digital psychology service, and we employ a broad range of fantastic mental health professionals to deliver psychological assessments and treatments to about 30,000 Australian adults each year. So I'm really interested and passionate about supporting mental health professionals to learn to use digital mental health tools in their everyday clinical practice. Thanks, Maureen.
Wonderful. Thanks, Nick. It's great to see you again. Over to Sue.
Good day. Thank you. Thanks, Maureen. And what great company to be in tonight or this morning, wherever you are in the world. I'm Sue. I've worked for longer than I'd care to mention, but about 30 years, mostly in the voluntary sector in mental health in the UK and New Zealand, and now globally, seeking to push for social change and justice for mental health because of the very, very endemic stigma and discrimination that still surrounds mental health in every culture and context around the world. So I've worked in various different roles for mental health charities, and the most significant last one was the founding director of the national anti-stigma program called Time to Change in England. We then worked globally, adapting with local partners and people with lived experience to push for social change and improvement in attitudes and behaviours in Africa and India. And I now work globally for a range of contracts and clients across global contexts. So most regions, working with ministries or NGOs, but more importantly, people with lived experience to share our stories as a very evidence-based way to tackle change. So what my interest here is, I think the two worlds need to come closer together: digital mental health, or at least digital methods, and the stigma field. And I think we could complement each other more if we work more closely together. Thank you.
Thank you so much, Sue. Looking forward to hearing your expertise in the session. So for those of you who know Liz Ashall Payne, you'll know that that is not Liz in the photo today. That is actually her colleague, Tom Mickelwright. And Tom is joining us today since Liz is not able to make it to the session today. We're very pleased to have Tom joining us. Tom, over to you for the introduction.
Thank you, Maureen. And I'll start by saying Liz sends her sincere apologies. She would like to be here, but she's feeling incredibly unwell at the moment. So my name's Tom Mickelwright. I work as a general practitioner or family physician in the UK, and I've been working in that capacity for about 12 years now. And alongside that, I still see patients to this day, but I also work in digital health, and that's where I developed my expertise. My passion really is for empowering patients through digital technology and also supporting clinicians to embrace the routine part of their practice. And so it's a real privilege that I get to work as medical director at ORCA. For those that haven't heard of ORCA, it stands for the Organization for the Review of Care and Health. And it's the leading organizations for evaluating digital health technology and embedding it into routine healthcare practice. We've conducted over 20,000 digital health assessments. We work with fantastic partners in health systems across the world, all with the aim of trying to get safe, effective digital tools to the people that need them most. So I'm really privileged to be here and looking forward to the discussion. Thanks, Maureen.
Wonderful. Thank you so much, Tom, for joining us. Great. So we are going to get into the panel discussion now. A reminder for attendees that you can post your questions into the chat. And the panel discussion is going to be the bulk of our webinar today. We're going to have some back and forth between the participants, and we'd like to kick things off with people's individual experiences at Congress 2024. Curious if you did attend Congress, feel free to put your name in the chat as well to engage with the audience. But it was just a wonderful experience for so many to be able to come together in the eMental health community in September of 2024. So curious about what was a moment or insight that really struck you about clinician engagement in digital mental health. And you can feel free to share a story from the event that you think we can carry forward. And I'm happy to kick things off. So one of the items that really is memorable for me at the eMHIC Congress was around the eMental health strategy for Canada launch. And we were so fortunate at the Commission to be able to launch this strategy at such an important event with the eMHIC Congress. And one of the key priorities in the eMental health strategy for Canada was support for the mental health workforce to integrate eMental health into their practice. We know that mental health, the workforce, is the backbone of the mental health care system. And it's so important that we build understanding and trust, as well as training and deepening understanding of opportunities as well presented by eMental health solutions and tools. And we've heard that during COVID especially, but unfortunately it has been continuing, that people have been asked to switch from in-person services to digital solutions very quickly, often without any training. And this is something that we see really needs to improve. We also know that there is a lot of burnout in the workforce at this time, and there are many other psychological challenges faced by mental health care providers. So in pointing to the eMental health strategy, we really must take care to support this workforce through the transition to eMental health service delivery without adding extra burnout. And it's really about comprehensive training, making sure that people feel confident in their ability and being able to trust the solution as well, and ongoing support for eMental health implementation for the entire mental health care workforce is what is recommended. So that was a key takeaway for me at the Congress. And perhaps next, I'll hand it over to Nick to share any key insights from your side as well.
Thanks, Maureen. And yes, it was a great Congress, and there was so much great discussion about so many topics. But I think you're right. The topic of clinician wellbeing training was one of the big standouts for me. But what I'd like to reference is actually the great presentations that explored engagement with consumers. And what I really enjoyed learning about was how other services are using incentives, reminders, even gamification, or nudges to prompt, support, and engagement and retention during an intervention. And what struck me was that incentives aren't just relevant to consumers, they're also really important for clinicians. And the talks at the Congress reminded me that clinicians, like all of us, do what we're funded to do. And going back to your point, we saw that during the COVID pandemic. Many clinicians, many of my colleagues and everyday face-to-face routine care used digital tools for the first time because their government funded telehealth. And despite the challenges that many of them experienced, most found that it added value to their work. But what was important to note also, at least here in Australia, and I suspect in a number of other jurisdictions, was when governments removed funding for telehealth after COVID settled, clinicians went back to traditional in-person models of care. So I guess in reflection, one of my key takeaways from the Ottawa Congress was the importance of incentives for changing clinical practice, not just changing the behavior of consumers, but also importantly for clinicians. So I'll leave you with that one, Maureen.
Yeah, that is wonderful, Nick. I'm so looking forward to hearing a bit more about that. I hope you can expand on that a little bit later as well. Great. I'll hand it over to Sue next to tell us a little bit about any highlights around clinician engagement.
Well, I think I would probably say, rather than a highlight, I'd say the issue is lack of it. I mean, there is engagement, and there are developments, and there are innovations, and there are strategies, which is brilliant. But it's like the same with any audience and any new approach or methodology or transformation where you're integrating innovative approaches into traditional models, I guess, is you've always got to start with where the audience is at if you want to engage them. And mental health professionals and, digital professionals, we're all the same. We've got the same drivers, motivators, barriers, fears, phobias, anxieties, whatever you might want to call them. And I think, Maureen, it's interesting to think about how you focused on workforce development and motivation and engagement and, taking care of mental health professionals working in the digital field, because I think you've got to go back to, if you want more engagement from clinicians, then you've got to spend more time understanding what's driving them. What are the motivators? What are the enablers? What provides psychological capability around this for mental health professionals? Understanding the barriers and asking them what would work for them. What are the enablers, whether it's systems, policy, funding, or their own psychological capability and fears and understanding or lack of it. So I think if you want more engagement, you've always got to spend more time with your audience, and obviously motivators and incentives are helpful for all audiences. But if we want behaviour change amongst an audience, you've got to spend more time with them, and then you've got to build engagement and plans alongside what they tell you they need and they want. So for me, it's just like basic behaviour change theories and strategies. Even if we're working with mental health and health professionals, it's the same deal needed.
Yeah, that's a great point, Sue. It's certainly one that we'll talk about more in the webinar as well, but the engagement of clinicians throughout the process. But also the point you touched on around the follow-up as well, which is so important to be able to actually show action. So not just, listening, but actually acting on the feedback as well, which is so important. So thank you so much, Sue. Tom, over to you.
Thank you, Maureen. So unfortunately, I wasn't able to make the Congress, but I've caught up with Liz and had a few conversations afterwards about it. One of her reflections, and one of the things we have spoken about, was that there's some fantastic pockets of learning and best practice internationally when it comes to clinician engagement. But what we've yet to achieve is an at-scale, consistent and systemized approach to really embedding digital health into routine practice. And it's no wonder, because the digital health world is massive. If you think about With healthcare professionals, they might spend an entire undergraduate course and then significant postgraduate training, learning about different treatment modalities, talking therapies, prescription therapeutics. And all of a sudden, in the space of a few years, it seems, we're bringing this world of digital health, and suddenly they're having to learn about wearables and remote monitoring and health apps and data and AI. It's a vast amount to suddenly have to assimilate alongside doing a really, really busy day job. But we can't just keep burying our heads in the sand. Patients are starting to access these technologies, whether we're there to guide them through it or not. They're still going to be accessing themselves, these technologies, with all the risks that are associated with it. And so I think there's an obligation, a moral obligation on healthcare professionals to rise up to the challenge and catch up with patients when it comes to the digital health revolution. That means closing the gap when it comes to undergraduate clinical education. And it also means embedding a systemized approach to ongoing professional development as well, continuing professional development to make sure digital health is an ongoing part of that. If we can do that, we can start taking bite-sized chunks out of this huge problem of digital health adoption and the vast array of options out there. And it also means we can start building the confidence of our workforce to start leading when it comes to digital health and driving change with some of these technologies.
Yes, it's so true, Tom. And actually, one of the comments in the chat touches a bit on what you're explaining. So Heidi from Brisbane, Australia, was talking about the words cognitive bandwidth, really speaking to kind of all of the array of wide information out there right now that we're trying to share with clinicians, often extremely fast, while they have so much else on their plate as well at the same time. So it's really speaking to kind of making that time for training, and to Heidi's point as well, making it brief and relevant and engaging so that they can take it away and use it in their practice. Like you said, Tom, as well, to be able to catch up with what patients are already doing and what they expect. Thank you. So now I'd like to turn it over to Nick for my next question. If you were at the Congress, you'll recall Nick actually convinced everyone that it was Anil's birthday during the eMHIC Congress, which it wasn't, but you made a really great point of bringing people together in that moment. The MC even got up and sang happy birthday to Anil. So it was really well done. Anil played along great as well. So Nick, I'm going to hand it over to you next. In your role at MindSpot, can you share a specific challenge you've encountered with clinician adoption of digital tools? And how does that reflect the broader conversation we had at the eMHIC Congress?
Thanks, Maureen. And that's birthday call is actually one of my party tricks. I try to do it at every conference, and it's really it lightens the mood, but it also helps to make points and brings people together. And I think that's really important. And can I just thank Sue and Tom for their comments? There's a lot that you guys are talking about that's resonating with our experiences here in Australia. Now, Maureen, the Australian MindSpot digital psychology service employs a broad range of mental health professionals, and we employ people with a really I guess, diverse set of backgrounds. Some people are new therapists, some people are very experienced, either counselors or psychologists or even psychiatrists or social workers, occupational therapists. But we've identified a consistent challenge, which I think really speaks to what Tom was talking about, and that is, even though clinicians new to our service may have had many years of experience delivering face-to-face care, that they're not often trained in how to use digital tools. And that's not just about skills, it's actually also about confidence. And one of the things which we've done at MindSpot is we've created what we call the MindSpot Academy. And the aim of the academy is actually to train not just new therapists to learn to use our digital tools, but we also use the academy to offer placements to students from, I think now it's about 11 or 12 different universities across Australia. And what that means is we can contribute to the clinical training programs across Australia with the aim of helping to contribute to building a future national workforce. Now, the Academy uses a competency-based framework to train new clinicians, and that's really, I think, one of the key principles which we've found to be successful. But what we've also found is that all of our clinicians, when they first start with us, at a cognitive level, believe or understand that our digital mental health tools can work. But it actually isn't until they've had the experience of working with a minimum number of people that they actually really truly believe in their heart of hearts that it actually works. And I just raise that because there's a difference between, if you like, thinking or understanding and believing through experience. So I think this is actually really consistent with what a lot of people reported at the Congress, and as Tom indicated, there aren't enough training programs across the Western world, certainly, and certainly in other places it's more difficult. But it's not just training, if you like, the new therapists. It's also, I think, to Heidi's point in the chat, it's also about training the existing workforce as well. So one of our big takeouts at MindSpot, and one of our big challenges has been, how do you upskill in the context of, if you like, the traditional training programs not providing that training? And our solution has been we do it ourselves. And we'd like to think that that's going to be time limited, and that the existing institutions will pick that up. But until then, we feel we have a responsibility to do that.
Thank you, Nick. If you have any recommendations as well on training programs, or, if you come from an organization, like Nick, Tom and Sue, that you have training programs that might be helpful for clinicians, I'd love to recommend that you put it into the chat as well, so people can take a look at these. I'll also share our e-modules for e-mental health implementation from the Mental Health Commission of Canada, which is a free online course. But to your point, Nick, I think we do, need better training programs. That was also, a recommendation in the mental health strategy, is thinking about, what resources we have that we can provide to people. So yes, please feel free to add. Also, if anyone is participating that has any resources they would like to share, feel free to add it into the chat as well. So thank you so much for that. Great. So let's think now about stigma. So we know that stigma can be a major barrier. Sue, would you be able to share with us an example of how anti-stigma campaigns have successfully changed minds? And also, how might we apply those lessons to help clinicians embrace digital mental health solutions and move the dial in adoption?
I think the second bit probably reflects what I said as an opener, but I just wanted to say one thing before I answer that question, which I should have said at the start. Do you know what I learned? One of the biggest things I learned at the Congress was, that we shouldn't, not to see digital over here and mainstream mental health services over here and this massive sort of gulf in between. It's, we need to look at full integration where there's complementarity, rather than thinking one's replacing the other, or, are we closing the treatment gap by bringing digital, being able to do more at scale and meet people where they want to receive support and services? And I think that's what struck me. It's not either or, and it shouldn't be something over here and something over there, and then you're trying hard to ram them together. They should absolutely be seen as two parts of a whole system, and mental health services and support, that it's much wider than that, but that we should absolutely from the outset be seen as complementary to each other rather than competitive. And I think the mindset is what needs to change, but well, that's another story. But the one thing I wanted to say was, do you know what, I was just thinking about this and thinking about it from both perspectives of the practitioners and the professionals and the policymakers and the people like me who also use mental health services. And not that they're two separate audiences, because mental health and health professionals have lived experience as well. But I remember being told that during COVID that I was going to have online CBT, like group CBT for acute anxiety, and I was like, oh, really? What because to me, as a client, a consumer, somebody who's lived experience, I had my own preconceptions about that. About, what do you mean it's not good? Of course, it's not going to be in person. It was during COVID. So there are a lot of assumptions and myths and misunderstandings or lack of trust or faith or confidence, and they sit in both audiences, both the professionals and the people waiting to receive or receiving the services. And it was the best therapy I have ever had, doing online group CBT with, you know, all kinds of people from all kinds of walks of life from my sort of region in England. And it blew me away how effective it could be online. So I had a prejudgment and a lack of faith and confidence in it. Obviously, the therapeutic professionals didn't, but I think, you know, there's a lot to do to educate people. And so just going back to the question is, how do you change minds and behavior? So it's not just changing knowledge and attitudes, you've got to change people's behavior around stigma, because ultimately what we want is reduced exclusion and discrimination around mental health. So yes, I mean, we ran Time to Change for 15 years in England. It's one of the most evaluated national anti-stigma, anti-discrimination programs in the world. Colleagues at King's College London did the thorough evaluation, and we had to prove that at a national level across England, getting a whole movement behind us with many parts of society behind the movement, were able to shift attitudes at a national level. I can give you all the percentages. They're ingrained in my brain. 12.7% attitude change throughout the lifetime of Time to Change. And this is the same sort of tool that had been used to measure attitudes in England since 1993. So the longitudinal data, was vast. But more importantly, we reduced discrimination reported by a survey developed by Graham Thornycroft and colleagues at King's College London, the IPPN, whether people had experienced less, more, or the same level of discrimination from the previous year. And this was across 1,000 people who recently used secondary mental health services across 5 mental health trusts in England. And we asked that every year and then every other year over 14, 15 years. And it saw big dips in levels of discrimination, something like a 15% drop in mean average levels of discrimination. So that meant that people's lives were improving. It wasn't just people saying that they'd changed their minds or, some sort of interim behaviour changes. This was less discrimination. So we were able to do that. But it's not just England. We have big global networks on stigma sharing learning across income settings and a whole range of cultural contexts. So it's a big learning network on stigma and a lot of evidence produced in a Lancet Commission report on ending stigma and discrimination in mental health. So that's the kind of, if you want all the data and all the evidence, that was published on World Mental Health Day 2022. So dip into that. And there's a new toolkit on addressing stigma that came out from the World Health Organization this World Mental Health Day. So there are many tomes of the most evidence-based approaches to do it, which the final thing to say is it has to be context specific. So, it's not a one size fits all. It needs to be adapted by people with local experience and audiences to each context. But there are known evidence-based ways. Yes, so it can be done. It has been done, sadly not being done in every part of the world.
Wonderful results, Sue. Congratulations on that study as well. And I think you touched on an important point around choice at the beginning. So, you indicated perhaps some people's preferences are in person, some people's are online, but I think the important piece is really around flexibility and choice and being able to provide people those options for what works best for them. And we also know that some populations also gravitate more towards online services for stigma reduction. They feel it does. It's a bit easier, perhaps, not having to walk physically into an in-person service, having your friends and neighbors see you going to that office. I also hear from our friends at Eating Disorders Nova Scotia that the eating disorder population often feels less judged in an online environment as well. So there's many different reasons, in terms of stigma where an online service could work for certain populations. But I think such an important point around kind of the need for choice as well. And I did want to open it up to see if anyone else would like to comment on Sue's great results as well with her work in stigma. Nick or Tom, did you have any comments for Sue?
Well, can I just jump in there if I may, Tom? I think it's outstanding work, Sue. It's really inspiring both at a local level and also globally. So thanks very much for your leadership. It's fantastic work. Well done.
Thank you, Nick.
Likewise, really impressed with the work you've done, Sue, on such an important topic. And Maureen, I was going to echo your point about some of the research I've seen as well that shows it's interesting. There's a common I suppose there's a common conversation that's had in the digital world, that a worry that digital will exacerbate inequalities or maybe worsen stigma, or those from groups that already face barriers that might make it even difficult for them to access healthcare. And I think that's an important point we need to bear in mind. But what the evidence has shown in some circumstances is those that face some of the greatest barriers, including stigma when it comes to accessing mental health, do find it much easier using digital services. So yeah, similar to your point, Maureen, but also it just chimed with me when you mentioned about your experiences of perhaps going into a digital service with a certain expectation and finding actually, for all the right reasons, it actually didn't meet your expectation. It kind of surpassed it.
Yeah, it's so true. Yes, thank you so much, Tom. And yes, a big congratulations, Sue, as well, on your success in this area of stigma, which we know is so important. And Tom, I'm going to get you to keep talking, if you don't mind, for the next question. But I did also want to show that Heidi shared a few resources as well in the chat around training programs. So thanks so much, Heidi, for sharing that. And thanks for raising that point as well, Nick. So
sorry,
Tom,
Maureen. There's also a Q&A, something in the Q&A. Sorry, Tom, from an anonymous attendee. Did you want to?
not seeing that. Apologies.
Can you see that where it says, how do patients perceive the effectiveness of virtual therapy compared to traditional in-person therapy, and what factors influence the perceptions? Which is, I only mentioned that because we were kind of talking about that, weren't we? Like these preconceived preconceptions about whether online is going to be as effective.
Yeah, sorry, I'm not seeing that, but please, would you mind repeating that, Sue? And then certainly we can address that question. Yes.
Yeah, sure. It'd be great to know if Nick or Tom have got responses. How do patients perceive the effectiveness of virtual therapy compared to traditional in-person therapy, and what factors influence their perceptions? So, you know, it is all about people's perceptions, isn't it? Like mine, which was, it wasn't going to be very effective, which was, yeah. So is there any research around that? Do people think online's going to be less effective than are there preconceptions around that?
Can I say there's you can probably break that question down into a number of components. One is, what is people's perhaps preconceived notions before they try, and then what are their notions and perceptions during, and are there comparisons, head-to-head comparisons? And there are actually quite a number of papers that have been studied or reported that have explored that latter question, that is randomized controlled trials where face-to-face has been compared to an online treatment intervention, and consumers at baseline and also 2 weeks after treatment have started have been asked about their sense of the credibility of the treatment, the likely success of the treatment, and usually there's no difference. And that, I think, is a really important outcome. But bear in mind also there are lots of different, as Tom was saying, versions of digital, just as there are many different versions of face-to-face. But I think our overwhelming experience is that when people try it and they realize that the content and the process is helpful and valuable, that it's respectful, people benefit, they engage with it, they find it meaningful, it speaks to them. But going back to the Congress, I think one of the best quotes I heard was, the best treatment for somebody is the treatment they're prepared to do. And we need to remember that we're just one extra, if you like, component of most contemporary mental health systems. Some people prefer face-to-face, some people prefer digital, some people like both. So it's a bit of horses for courses, so to speak. But I think it's important to add value to traditional services as well.
Thanks, Nick.
Absolutely.
And I think the thing I would add to that as well is from research we've undertaken at Orca, generally people will have a preference, or they believe they have a preference for face-to-face therapy. So there is that kind of an initial expectation. But then we're working in a resource-constrained healthcare environment. I think wherever you are in the world, it's a resource-constrained healthcare environment at the moment. And so often when people are given the choice between waiting an inordinate amount of time for face-to-face therapy or using virtual therapy, which might be more flexible at times that work for them, they can do it from home or access those services a little bit faster, that seems to significantly, in fact, impact people's willingness to try those therapies. And like Nick said, when you actually look at the clinical outcomes, they're pretty comparable.
Yes, it's so true. Thank you so much, Tom. So Tom, a key focus at Orca is about making digital health accessible. Could you tell us a little bit about your techniques and approaches you have just deployed to resonate with clinicians and encourage them to adopt these tools?
Yeah, gladly, Maureen, and thank you for the question. We're taking clinicians on a journey with digital health, and it's not fair to expect them to do all the walking. We've got to meet them part way, and that means taking digital health to where they are right now, today. And by that, I guess what I mean is we need to, instead of expecting them to change their entire working pattern to accommodate digital health, we need to look at how we can assimilate digital health as much as we can into their existing patterns of work. Speaking from personal experience, when I've been introduced to a new software in my practice and I've been told, if I'm told there's brand new login details I need to memorize, a whole new platform I need to learn to navigate, multiple windows and screens where I feel like I'm duplicating my work and my written entries, then you're just going to really struggle to engage clinicians and embed that in practice. What you really need to do is make the transition as easy as possible. So within Orca, one of the things we've been doing is building tools that integrate with electronic health records and mimic the natural prescribing journey that most clinicians are really familiar with. So it's as easy to recommend a digital tool as it is to prescribe an antidepressant or an antibiotic. And clinicians can search from a comprehensive suite of different solutions that have been pre-approved for inclusion on a formulary. That's exactly the way pharmaceuticals work, and it's a very natural way for clinicians to work in. It's easily assimilates into their existing workflow. The other thing we've done to try and, I guess, align with the values and practices of clinicians today is we've started mapping particular products to individual patient needs to help clinicians make a personalized recommendation to a patient. So to give you an example, if you take a patient with an anxiety disorder, there's not one treatment for anxiety. We don't operate in that way. Depending on what their particular needs are, they might access face-to-face or virtual therapy. They might access SSRIs, beta blockers, talking therapies. And that's to say nothing for if they have audio or visual auditory impairments, or perhaps they're from a cultural or ethnic background that requires a very tailored approach. All those things are important to clinicians if we're going to really live up to our values of person-centered care. And that's what we're trying to do at Orca, trying to break down this idea of one solution for one problem, trying to make that marketplace of thousands of solutions a bit more digestible, and trying to say, here's a solution that can help with this problem. Here's a solution that can help with these types of patients. And what that's led to, the natural culmination of that work, is sitting down with clinicians and patients, mapping out an entire care pathway and identifying all the different touch points on that care pathway where different solutions can be used. That's a way to align digital health with current thinking, the current paradigms, and it's really been helping us to gain adoption.
Thank you very much, Tom. And we certainly appreciated all the work that Orca has supported with us around our app library and assessing apps at the Canadian level. So thank you very much for that. I know that you also at Orca can also provide a provider login for clinicians to go in and be able to assess apps, which is a wonderful feature, and really making it relevant, like you were saying, for clinicians to be able to select the tools that work for them. So thank you very much. Great. And I do see that there is both a Q&A and also a chat. So I did want to share that feel free to put your questions into either the Q&A or the chat, and I'll monitor both. And I did want to open it up to Sue and Nick if there was any questions or comments from what Tom has been sharing.
Well, Tom, again, congratulations to you and Liz on the great body of work that you've embarked on over many years. We use Orca here in Australia. I'm sure, based on Maureen's comments, it's clear that many other jurisdictions do as well. But I guess I've got some questions for you about how you see emerging technology being integrated into the services or the apps that you are comfortable for clinicians to use. I'm not sure if this is the right time, but we might put that on the list, Maureen, if that's okay.
Please go ahead. Yes. Tom, would you like to answer that one?
Yeah, so I mean, by emerging technologies, are you thinking in terms of artificial intelligence, I suppose, is the big one that people are a lot worried about, and how we'll kind of regulate that and keep that safe for our patients and clinicians? Or were there other technologies?
That's one of many, but let's I think that'll maybe take the next couple of hours. But perhaps any comments around that? I'm sure everyone will be really interested in, Tom.
Sure. So I think it's very difficult when you're working in the regulatory and the safety space to keep pace with emerging technologies. I think it was probably, I mean, even now we're just starting to reach a global consensus on high-level principles we should use for evaluating AI. But we're still some time away from a concrete, practical framework for actually assessing it. What are the key questions? What are the key tests we should be deploying? What are the key metrics we should look for when it comes to AI? And even AI is moving rapidly. I mean, 18 months ago, I don't think any of us were probably using large language models. And now we routinely across products that are embedding large language models into their solutions. And that poses all sorts of challenges. There's a market pressure for industry to adopt some of these emerging technologies to appear current, and some of those suppliers don't fully realize some of the ramifications in terms of regulation, turning simple products into medical devices all of a sudden, but also the burden on them to demonstrate safety and evidence suddenly shoots up when you've got these seemingly limitless AI models. So there's a challenge for regulators, there's a challenge for suppliers not to overstep their reach, but then it's a careful balance with clinicians as well. I don't like stifling innovation, but I've certainly seen clinicians rush to embrace some technologies without necessarily realizing that they're going in blind in some instances and potentially exposing themselves and their patients to risk. So we need to collectively, we need to think about how do we disseminate that message that there are new technologies, they hold great promise, but we do need to take a pause until we reach a kind of professional consensus around what does safe look like, what does effective look like, and how can we implement them in as safe and protected a context as possible. So it's huge challenges there, Nick, but we're trying to keep pace and working with a lot of regulators globally to adapt the standards we use for evaluating technology.
Yes, it's a great question. And I know that clinicians are actively using AI for clinical notes, being able to condense materials into summaries that can then be translated to kind of their electronic health records, making it quicker for them. Predictive technology as well for predicting patient outcomes. So many uses, but I think, as Tom mentioned, the real question is around the safeguards for AI across all regions. So we're looking at that currently in Canada, following closely Bill C-27 in Canada around federal legislation for artificial intelligence, but also closely looking at AI for mental health services as well, since there are some unique challenges for mental mental health services, for example, like a human-centered approach to technology, as well as transparency. And one of the topics that I wanted to talk about today as well is incorporating lived and living experience into technology. So perhaps I'll go to Nick and then Sue with the next couple of questions. The first is around collaboration. So I'd like to come back to this topic. And then the second one I wanted to ask Sue is around just what we had chatted about, lived experience and incorporating kind of the lived experience voice as well into technology. And I think kind of both of these topics go hand in hand. So Nick, for collaboration, how crucial is clinician engagement in product design and development? And in your experience, how has that influenced engagement so far?
Oh gosh, great question. And look, I think it's really important to acknowledge that, like consumer engagement, clinician engagement is essential in design and development for lots of reasons. And just, I guess, three key reasons that we've observed include that clinicians have critical insights into what should be included in the clinical content of a treatment program, just to ensure that it's evidence-based, but it also is likely to resonate with consumers. The second reason is that clinicians often have insights, and quite deep insights, into the essential UX or UI design features of a treatment program, partly to ensure that, as Tom indicated, the new intervention actually fits within their clinical practice and doesn't increase their burden. But they also invariably have insights into how consumers will engage and what their experience of the workflow will be like. But thirdly, and I think this is important from the perspective of thinking about product development, but also quality assurance, clinicians, after they've experienced and used the tool for a while, they invariably have a lot of experience and knowledge about what actually is helpful and what isn't helpful. And they can provide advice about potential modifications and improvements based on their experience and outcomes. So I guess, very simply, we see clinician input as an engagement as adding value at multiple levels of the so-called product journey, including development of good content, UX, and also quality improvement. And probably the last thing I'd add there is, obviously, if we value our clinicians, if we want them to feel empowered and successful, then we want them to have an active voice in the development and not just the delivery of interventions.
Yes, absolutely. It's so important, Nick. Thank you so much for raising. It reminds me of one of the provinces that we have in Canada, Newfoundland and Labrador. They have a chatbot on their website. And one way they're involving clinicians is they actually pay clinicians to review all of the scripts of the chatbot as well, and be able to monitor it to make sure that, the scripts and the answers are actually correct and hitting home and relevant for the population. So it's just so important, not only in the development of the technology, but also all the way throughout the process as well. Thank you very much. And I'd love to also chat, it's related, I believe, as well, not only about clinician engagement, but also about lived experience engagement as well, Sue. So I'm wondering if you could tell us a little bit about how we can incorporate those voices into our understanding of success in digital mental health, and how sharing those stories really influence clinician engagement and adoption.
Yes, I mean, one would hope that in many parts of the world, and it certainly won't be all parts of the world, but the absolute priority and vital focus of having people with lived experience from the outset of any discussion, let alone like at some point during product development or innovation, this should be a co-productive approach from the beginning, with designers, with mental health professionals, with people with lived experience. So you want a whole sort of range of perspectives right from the outset, because you can't design something. I mean, I think, Tom, was it what you were saying, and Nick, you were saying this as well earlier, is you've got to go to where people are and what people want and how they want it and when do they want to use it and what format do they want it in and what platform do they want to use. And the only way to get that information is to involve people that you're going to target, as potential future users of these products or services from the outset. You wouldn't, design any other project without thinking about the end user in mind from the outset. So why is it any different? So it's not only the most effective thing to do is to have lived experience input from the outset. It's also the right thing to do, like nothing about us without us. There's a sort of core moral principle to this work. And sometimes we get that right in mental health and sometimes we don't. But I would think most people have moved on a long way in the last 10 or 20 years. But digital's the same, so we should be taking the same approach. But I think for me, we need to speak the language of people that are going to use the service. And I wonder if that's also something that could be helpful to think about ways of engaging clinicians. So I think it can be quite bamboozling to have too much information. I wonder if what you want to know is, what is the benefit you're going to get from it? And often the best way of hearing how a digital product or service, whatever it might be, is going to benefit is to directly hear from people that have benefited. That's the best promotion you could imagine, is to hear someone saying how they benefited and maybe the pitfalls and maybe their reservations, but how they overcame them. So peer-led advocates or ambassadors, and that could include mental health professionals as well, whether it's therapists or counsellors. A lot of us have all had our reservations or hesitations or lack of trust or worries around safety and safeguarding and risk and everything else. But actually the best people to talk about it are the people that have been there, seen there and done it and benefited from it, both from a lived experience and a professional perspective.
That's so true, Sue. And imagine developing a technology without clinicians and lived experience expertise, and then finding out at the end that it completely doesn't work for clinicians, nor those with lived and living experience, which happens. I think it's so important to be able to engage clinicians and lived experience expertise right from the beginning, all the way throughout the process. And you made a great point. It's not only the right thing to do, but it's also an effective way to ensure that the product is relevant. So thank you so much for that.
I think just one final thing to add is you need to acknowledge what people's fears and misgivings or lack of you need to acknowledge what these are, not just blindside people by trying saying, oh, it's going to work, it'll be brilliant. You've got to acknowledge where people are at and then move them forwards like you would do with any other campaign. So you can't just expect people to take your word for it. You've got to acknowledge that there are some major barriers here. Sorry, Maureen.
Yeah, no, actually, and even going back to what we discussed at the beginning, and then action that feedback. So that's the other critical part, is not just seeking the feedback, and addressing the barriers, but also really actioning what the feedback is. So yeah, great point. Great. So I'm mindful of time. I wanted to invite all participants, if you have any questions, now is a great time to put your questions into the chat or the Q&A, and we will monitor those. But I would love to open it up for any discussion with Nick, Sue, and Tom. And Tom, I would also love to ask you a bit more around trust in digital technologies as well. But first, I wanted to open it up to the group to see if anyone has any further comments around these topics.
Perhaps while we just wait to come in, to your points, Sue, a colleague once said that in the digital health world, there's a real risk that we find a shiny new hammer and then we go running around looking for a nail to hit it with. I think we often see that. There's a real temptation, especially with emerging technologies, to just find a way to make it work and then find too far down the line actually it doesn't solve the problems that your clinicians or your patients have. So definitely get that intel right from the start.
Mm-hmm. That's so true. Yes. Thank you, Tom. So perhaps, Tom, now I'm wondering if you can tell us a little bit about trust, because recognizing that trust is really essential. We know that people, including clinicians and users of products, are more likely to want to use a digital health product and service if they know they can trust it. So I'm wondering if you can tell us about how does ORCA work to ensure that clinicians feel confident in the digital tools that are available to them?
Sure. Thank you, Maureen. A few years ago, Orca did a really fascinating experiment that they published. It was a discrete choice experiment where they had a sample of, it was 100 clinicians, and they presented them with two digital health technologies and a short feature set, a bulleted feature set side by side, and the clinicians had to choose which product they thought was the most trusted. And they repeated this again and again and again with multiple different combinations of products to see which features which features really tipped the dial in terms of generating trust. And what they found was the usual things you'd expect: safety, evidence-based, regulatory compliance were really important, but they were table stakes. They were the bare minimum the clinicians expected to be there. The thing that actually carried the most weight, and it had the same influence as 5 published research papers, was organizational approval. Was an organization saying, a trusted organization saying, this is an approved technology. So what does that tell us? Well, that's informed a kind of 2-stage approach to generating trust for Orca. The first thing we do is we pay attention to the regulatory compliance, the safety, and the evidence base, but we try and distill all that information, which is overwhelming to your kind of average clinician understanding about ISO and FDA and eMHIC. We try and distill into a really usable metric that a clinician can look at a glance to determine whether or not a product is to be trusted. And then the second thing we do is we partner with respected, trusted organizations to build repositories of approved digital health products. That's the work that we've done with yourself, Maureen, at the Mental Health Commission Canada. It's the work that we've done with national charities like Mind in the UK, a national mental health charity. And it's the work that we've done with health systems and national governments across the world, kind of, I suppose, partnering, demonstrating trust and approval and endorsement from these respected organizations, creating a safe space for clinicians to go and find trusted technologies.
Thank you very much, Tom. And we certainly appreciate all the work that you're doing as well to be able to build trust in the e-mental health community. Thank you very much to yourself and Orca for all that you're sharing and all that you do. Wonderful. So knowing we only have a few minutes left, I wanted to also share that we have a comment as well in the chat that I think is also really important in taking prevention and care to people where they are likely the most, or there is likely the most direct path to scaling mental health system and support accessibility. So true. And also the incentives coming back again. Like, I think that is also really important. Kind of why would somebody go the extra mile to be able to engage in this training and be able to add this on to their already busy workload as well. So very important points. And we also have a comment: in your view, what does the optimal, scalable, and sustainable clinician engagement look like? And these people are very often busy. So kind of speaking also to the comment above. So perhaps we can wrap up with this comment. I wonder if we wanted to go around the room, just perhaps with kind of 1 or 2 sentences around what you would see kind of as optimal. So reflecting on everything that we discussed here today, we talked quite a bit about engagement, clinician engagement, also creative ways to engage clinicians in training, having additional training programs, as well as incentives, which were mentioned. And then also not only clinician engagement, but lived experience engagement. So perhaps I see Nick nodding. So that is my cue that I think you're ready to go first, Nick. So perhaps I'll go with Nick, Sue, and then Tom to wrap up today's session.
Thanks, Maureen, and thanks for your great facilitation. Look, I think if I was going to summarize it really briefly, if a platform's easy to use, if it's effective for consumers, if it's efficient and there's good interoperability, and fundamentally, if it helps clinicians do their job more efficiently and easily, they're probably going to use them. So I think there's a big challenge for our field to achieve those objectives, but I think it's achievable.
Wonderful. Thank you so much, Nick. Over to Sue.
Nick, I think that was such a good answer. I think I've only got two quick things to say. One is, surely we should be thinking ahead. I mean, Tom, like you said, it's hard to keep up, but surely the vision is that you, wherever you are, you have a choice, whether it's in person, digital, or a combination of both. That people would hopefully have access rather than one replace the other or one sort of make one outmoded, but you still have a choice whether you would rather be in person or digital, for example, if it's a therapeutic intervention. So I think choice, like lived experience, client choice, is really important. And I think just secondly, I'm always going to go on about this, but we mustn't forget that whatever the digital intervention or product or service, there is still stigma there. So to think that people are going to start using digital without needing to overcome stigma. I mean, yes, you don't need to turn up to a building. You wouldn't be seeing opening the door for something, but there's a lot of self-stigma. It's not necessarily just external stigma, it's how people feel to even think about going online or to the GP or to be assessed online. You've got to get to the point where you've got to acknowledge that you're struggling, regardless of whether it's an in-person or digital tool. So I think we mustn't forget that either. Thank you, Maureen, for your great facilitation as well, and Tom and Nick for being such brilliant panelists.
My pleasure. Thank you, Sue. And choice is so important. Thank you for bringing that up. And Tom, lastly, any last point before we wrap up?
I would say optimal clinician engagement looks like what it's not is one-off initiatives to quickly try and get buy-in. What it is it's a consistent, at-scale, systemized approach with multiple nudges to keep reminding people to think digital when the patient's in front of you. So whether that's embedding it into ward rounds, poster presentations, conferences, webinars, journals, newsletters, constantly making digital health around us rather than siloing it over here is something else for us to remember until it just becomes an embedded part of our way of thinking when we're looking to support our patients.
Fantastic. Thank you so much, Tom. So important to come at it from different angles as well. So I would like to say a huge thank you to each of our panelists today, Tom Mickelwright, Sue Baker, and Professor Nick Titov. And thank you all so much for your participation and engagement. I hope you have a wonderful holiday break if you're celebrating, and also have a wonderful day or evening ahead wherever you are in the world. Thank you so much, everyone.